Imagine a single bacterial cell. Imagine the same bacterial cell enclosed by a cell wall protecting its genetic material from degradation. The same cell used against those with no choice, infecting them with a harmful and ultimately deadly infection by those who devalue the less educated and the less socioeconomically advantaged. Imagine that despite the existence of an effective treatment, this subset of people were allowed to perish at the expense of research. This cell would be syphilis. Such events took place in Tuskegee, Alabama, and again in Guatemala. Marginalized populations in these locations were used to study the symptoms and course of infection, putting numerous lives at risk to help find better treatments for citizens of higher standing. By examining the Tuskegee syphilis study, the Guatemala study of 1946, and current syphilis treatment options, I will demonstrate the blatant, unethical practices carried out in the treatment of marginalized populations in the United States and abroad, in order to advocate the need for public awareness of research and its practices. Researchers wanted to discover a treatment for the African American community, resulting in a study named Tuskegee Study of Untreated Syphilis in the Negro Male, which quickly collapsed in terms of ethics and bodily autonomy. Military orders were put into place preventing participants from seeking treatment, deciding the men would be followed to the death. Even after it was determined in 1945 that penicillin was the treatment of choice, the study continued until 1972. I argue that the Guatemala study of 1946 was put into action to protect soldiers who were deemed more vital to the human population, at the expense of sex workers, imprisoned, mentally ill, elderly, and the Guatemalan community. The ability of scientists to look past this malpractice relate to what Juan would refer to as epistemological ignorance. Tuana says, an important aspect of an epistemology of ignorance is the realization that ignorance should not be theorized as a simple omission of gap, but is in many cases an act of production. It is unlikely that the scientists involved in these studies were unaware of this malpractice, but rather chose to overlook it to fit their needs. In present day, the best treatment is limited to those in economically privileged positions, leaving a less effective treatment for those in poverty. Azithromycin is a generic form of penicillin, the drug of choice for treating syphilis. Azithromycin is used in San Francisco and other major cities despite the cautionary label. It has been shown that azithromycin is ineffective as a single dose, requiring multiple follow-ups and close supervision. Although cheaper, follow-up exams and multiple doses limit access to an effective treatment for those who may struggle to miss work or find a ride to the clinic. Even if multiple doses prove affordable, the high mutation rate and resistance of syphilis to azithromycin deem it inferior to that of penicillin. I hope to raise awareness that these studies are not isolated incidences, but rather stem from the same discriminatory systems that still control society today. I want to leave you wondering how, as a society, we are not more aware and outraged at events like this, but rather allow them to disappear in our cultural history.